Thank you, everyone, for being here tonight. We really appreciate this. My name is Christy Mitchell. I'm the Executive Director of SEBA. We're the South End Arts and Business Association. You may have heard we've recently acquired this incredible space. And you're our first audience, our first event. It's quite fitting that this is going to be a community hub, and here we are all engaged and concerned and thinking about our community and how we can all play a part. So I'm glad that you're here, and this will be the SEBA Center for the Arts. Next door you'll see an art gallery, our offices, but also an info center that'll be open regularly to tell people about the Arts District. We'll have performances, talk series, and all kinds of fun things in here. It's still to be determined. Come back next Friday for a Halloween soft opening. Dress up. And I hope to see you around the neighborhood. And thanks again for being here. I'm going to introduce you to Sam Donnelly from Building Burlington's Future, the executive director, who is impressing me already. So congrats, Sam, and on this event.
Thank you. Thank you, Christy. And good evening, everybody. It's nice to see so many of you out on an otherwise cold and rainy evening. I know there's nothing to do on Thursdays ever. So it's nice that we can provide some entertainment and some information and a good community conversation. I just want to start by thanking a few people who made tonight possible. Like 2 days ago, this list of thanks was about 2 people long, but in the last 48 hours before events like these, you forget about all of the things that goes into an event, and the list grows ever longer. So in no particular order, I want another round of applause for Christy Mitchell and her team at SEBA, not just for the space. Yeah, not just for the space, but also for providing a lot of vibrancy into the South End and bringing business and arts into our community and providing a place for those things to happen. I had told Christy the last time I was in this room for an event was when Waka Flocka Flame played a concert here just a couple of years ago. And Cam was there too. Yeah, we were probably having a lot of fun together. And then the time before that, it was Fresh Market. So, and that's even longer ago. I also want to thank Vermont Gas, who does not have a representative here, but they came in today and they turned on the heat. So if you're not warm enough, you can email Vermont Gas and let them know. I want to give a shout out to James Unsworth. I don't think James is here, but he helped facilitate the connection and made the space possible. Our panelists, Stan Hall, Candace, Gale, and Dr. Wolfson, Dr. Dan Wolfson, who are here tonight, they're all wonderful people. Our operations director, Emily Healy, who helps me keep together all of the logistics, finds the chairs you're sitting in. Speaking of those chairs, they came from Twin Craft Skincare, so they may or may not have smelled a little bit like soap this morning. And our wonderful friend Luke Autry for the sound support, Town Meeting TV for being here, Pat from, I'm going to get this wrong, WMAC? AMC for being here. And really, really importantly, Turning Point and Cam Lauf for being a wonderful partner, for setting up this conversation, helping form the dialogue tonight, and for all of the work that they do. And last but not least, our former mayor, Peter Clavelle, for moderating. It's really an honor to be able to do some of this work with you, have you engaged, and for you to be here tonight moderating the discussion. For those of you who don't know me, my name is Sam Donnelly. I'm the executive director of Building Burlington's Future. And I won't give you a full pitch on the organization tonight. I will just say that we're about 2 really, really important things: bringing people together and finding ways to make progress in our city. And those 2 things don't always, that's important. Yeah, thank you. It always helps to have a board member, Karina Driscoll, who, in the crowd who hypes you up. That's helpful. Those 2 things don't always just happen on their own. And without people getting together in rooms like these, having conversations, and then finding paths forward together, those 2 things don't happen at all. So a big part of our mission and our work is to bring people together, help people feel like they're part of a solution that they can pursue, and help elected officials. By the way, if you're an elected official, can you please just raise your hand briefly because I so appreciate you turning out. Yeah. I'm sorry to call you out, but it is so important to have not just community members in a room like this listening and with an open mind, but also our decision makers and the people we elect and put in those positions. I don't want to talk too much longer, but I just want to briefly introduce the evening. Tonight's conversation is about recovery, and recovery is at the center oftentimes of what makes our community work. It's about public health in Burlington, it's about safety and stability, and it's about belonging and inclusion in Burlington. I also want to end by just saying that not everyone in a room, when you gather people together, is at the same place on their journey of learning or growing or understanding any issue that's being discussed. And so I think it's really important in this particular moment and in our city to make sure that we're giving each other the grace and the patience and the space and the time to learn and to change our minds and to work together to figure out a path forward. And just because someone might disagree with you or just because you might disagree with somebody doesn't mean that we have to be at odds, but we should try to find ways to understand each other and where we're coming from in our personal experiences. And I wanted to say that just because I know our subject tonight can touch on some personal experiences for everybody in this room, whether it's someone you know yourself personally, a friend, a colleague, or if you're just here to listen. It sometimes can be harder work than usual. So I want you all to keep that in mind, and with that, I'll hand it over to our moderator, Peter.
Thank you, Sam. So, we all share one thing in common. We're all concerned citizens. I happen to have had the experience of serving this community as mayor for 7 terms. I also have the opportunity to serve on the board of this organization that I believe is making a difference in making things happen, building Burlington's future. And yes, I'm the moderator for tonight's event. So I'll try not to speak much, I'll try to listen, and I'll try to move the discussion along. But I just want to say that this community faces many challenges. And I'm not here, I don't believe tonight's purpose is to discuss those challenges in depth. We know what they are. And I am pleased to say, though, that I think we're making progress. Only today, and if you haven't seen it on the news, when you go home, you'll hear about it. Only today, the governor issued the second half of his response to working with this community to respond to some of those challenges. And I'm really pleased that we're seeing collaboration between the city, between the governor, between the state's attorney's office, between the stakeholders represented today, and there's a multifaceted plan that's being presented focused on short-term actions, and yes, there are longer-term actions that will be necessary, but the plan as presented today is short-term actions, but it recognizes that there are so many areas that need attention, from how we enforce laws, how we prosecute crimes, how we deal with mental health issues in this community, and how we provide folks with the treatment that they need, how we provide housing opportunities for folks. We're not going to cover all of that landscape this evening. But for this organization, BBF, to be effective, we need to advocate for policies that are sound and that will address the challenges that this community faces. So part of tonight is to better understand the challenges, but more importantly, the response to those challenges. So tonight we're going to take a slice of it. We're going to focus on treatment. So we're going to hear from panelists. I'm going to pose a few questions. We're going to have a conversation with these experts. Then hopefully we'll have time for Q&A from the audience as well. But I'm real pleased that BBF is able to play a role in bringing the panelists together, but more important, the community together. The only way that we're going to be successful in making Burlington better is if citizens are engaged. And I think that the turnout this evening indicates that citizens of Burlington are ready to be engaged, are ready to pitch in to address the challenges that we face. So from going closest to me, my left, I'll introduce the panelists all at once, and then we'll open it up. Cam Lauf, who I've gotten to know in recent days and months, is the Executive Director of the Turning Point Center of Chittenden County. Cam leads one of Vermont's largest peer recovery organizations, supporting people and families affected by substance abuse. Cam is passionate about building community awareness and engagement around recovery. We have a couple of Dans here. The closest one to me is Dr. Dan Wolfson. He's an emergency medicine physician at the University of Vermont Medical Center. He has been a long-term and leading voice in connecting hospital-based care with community recovery supports to reduce the cycle of crisis and relapse. Next, we have Candace Gale. Candace is the Director of the Community Relations for Vermont Foundation of Recovery. The foundation operates recovery residents throughout the state. Her work focuses on creating safe, supportive housing environments that empower people to sustain their recovery. And at the far end, we have Dan Hall. Dan serves with the Howard Center, where he works to expand access to mental health and substance use services across the region. He brings deep experience to community partnerships that connect people to treatment and to long-term support. So we have a great panel here. So the first segment of this focus of this evening, we'll hear from the panelists, then we'll open it up. But panelists, share with me, the title of today's forum is Recovery First. What does that mean? And how do each of you see recovery connecting to Burlington's broader issues and challenges related to health, housing, and safety goals? So we're not going to go this direction every time, but for a start, we'll go right down the line and start with Cam. So just a couple minutes each, share your perspective on how recovery relates to addressing the challenges that we as a community face, and a little bit about what you're doing in that field. Thank you.
Thank you, Peter. Hi, everybody. The concept of recovery first is currently being played out in San Francisco. And seeing it played out over the past couple of months, it's been a response to looking at compounding crises across multiple sectors affecting frontline support professionals, affecting healthcare professionals, affecting emergency responses, affecting business communities. All throughout the chain, we're seeing compounding effects brought on from the pandemic, a rapid response, which is forever a reactionary state of policy and practice. And here we are 5 years later, looking across the country and looking here in our homes and seeing a continued frustration. We're not here to discuss what the problems are, but it would be wrong of me to not allude to the fact that the work is hard. From all of us here that are representing multiple organizations, we're talking about medical frontline professionals, access to health care, the responsibility that's there, intervention and treatment in an outpatient, residential capacity, and an inpatient capacity. Vermont's continuum of care, starting with prevention, treatment, and recovery, including harm reduction when necessary to keep people alive. what we're seeing here today is individuals in recovery are having a hard time staying in recovery. It's also a lot harder to get into recovery. Recovery is the end goal. In most scenarios, for person-centered practice, individuals diagnosed with substance use disorder, recovery is the gold star objective. It doesn't mean everybody will get there. It's hard. I'm a person in long-term recovery. I'm coming up on 12 years. I'm in recovery from heroin addiction. My experience is similar, but it is not the same as every single individual that is struggling with use disorder. Each person requires unique services, unique supports, and most importantly, a community that believes in them, and a community that is responsive and embraces and continues to protect this state of being that they've given everything to get towards. A person in recovery has already lost so much and has already given so much to get to where they are. Lives are on the line, and lives are being saved. Folks are making changes, the work is continuing, and people are recovering. What we're seeing in Burlington, there are opportunities for us to continue to grow for all of the progress that's been made. Over the many years of implementing harm reduction, access to low barrier supports, low barrier housing, there's also an opportunity to build on top of that, to continue to grow access to health care, and to build a community that is embracing people that are in recovery and understanding that they've given everything to get there and we got to keep them there. It's hard being a person in recovery, walking through Burlington and seeing so many people struggle. The hardest part is seeing my friends struggle. People who I love. Seeing family members actively using. When we know that there is a better alternative that is out there, and more often than not, they want that. They're having a hard time getting there. So how can we help get them there in a quicker way? How can we help get them there and they can stay there, stay in recovery, and be a part of this community? They're already here. They're already a part of this community, and we need them in order to keep growing and keep doing incredible things. So just the conception of what Recovery First is, how this is playing out here in Burlington, and what does it mean for us, that's something I hope that all of us can explore. And that maybe there are some answers that we can come to, but that everybody can come away with maybe more questions, to think differently, and to also present solutions at the appropriate times. Thanks.
Thank you very much, Cam, for sharing that very professional but also personal perspective. We really appreciate you sharing that with us. Dr. Dan.
Okay. All right. Can you hear me? Well, I work UVM emergency department, so I have a little different view of the world because that's the environment that I work in. But Cam, thank you for those great words. And in our world, I think, first of all, recovery really is possible, right? Like, people can recover, and I think we do our little part to try and help people by providing appropriate treatment. 5-7 years ago, we were really doing mostly harm reduction. I mean, yeah, we could save your life if you came into the emergency department, but then you were just getting a brochure and a referral to a treatment program. And we've learned by working with these partners here and others that it's more than that, that we really need to actually offer people treatment in the emergency department, and then super important is to make the connections. So now when you come into the ED, thanks to the work of all these folks and others, you know, we can give you life-saving treatment, but then we can also offer you ongoing treatment for either alcohol or opioid use disorder or whatever is going on with you, and a warm handoff so that you get a referral in real time to somebody who knows us and we know them, and actually have guaranteed follow-up within usually the next business day, or if it's a Friday, you know, by Monday. So I just can't stress how important that is, and that I said recovery is possible. Like, just from a medical point of view, physiologically, the brain can rewire, and you can build those networks that allow you to recover. And I just think the medications that we use for treatment really help that process, but it's the whole package that makes it successful.
Thank you, Dan. It's very nice to hear that the emergency room is not only dealing with emergencies, but is attempting to connect folks after that emergency with the resources that they need to deal with their longer-term issues and challenges. Thank you very much. Candace.
Yeah. So my perspective is a little bit different dealing with recovery housing. Stable housing is really essential for lasting recovery, and recovery housing fills the gap between treatment and full independence. When people have a safe, supportive place to live, they're more likely to stay sober, engage in work or school, and rebuild healthy relationships. That's not just good for the individual, but it's also good for the community. From a public health standpoint, recovery homes reduce hospital readmissions, emergency service calls, and overdose risks. They help people sustain long-term recovery, which supports Burlington's broader goals of improving behavioral health and reducing the strain on emergency systems. From a housing perspective, our model complements the city's housing strategy by providing stability at a stage where traditional housing options don't always fit. It prevents homelessness, reduces shelter demand, and strengthens the pathway to independent living. V4 also works with affordable housing organizations like Champlain Housing Trust to make those completing our recovery residence program have a better chance of getting into stable housing. And so we work with them very closely to make sure that people have a place to live after they leave our homes. And from a community safety lens, recovery housing contributes to stability and civic engagement. When people have structure and accountability, they're less likely to return to crisis situations and more likely to become neighbors, volunteers, and community members, contributing to Burlington's strength. Ultimately, recovery housing is about creating a continuum of care, linking health, housing, and human connection, so that everyone in Burlington has the opportunity to recover, rebuild, and thrive.
Thank you, Candace.
Hi, everyone. So I'm Dan. I'm the Director of Outpatient Services at Howard Center. I think I'll speak mostly from a treatment perspective. Appreciate the comments of the panelists here. I think it's important to note that treatment looks different for everybody. Just as substance use kind of falls on a spectrum, we really need to be nimble and creative with the treatment options that we offer. Howard Center, I think the community has done a great job in building that access to treatment. We have over 900 clients on methadone at the Chittenden Clinic. We have over 500 on buprenorphine in our Spoke program. We provide other outpatient services, and I think across the board, the community has kind of built treatment access in, but it does look different, and everybody's journey is different. And I think a lot of what we're seeing now, we're talking about recovery, gold standard, absolutely. We also need to help people just stay alive so they have the opportunity to get to that recovery place. And so a lot of the work that we're doing right now, a lot of the work we're seeing is really around harm reduction. When I think of this prompt, though, I think about just how interconnected all of our services are. and how just crucial it is that we work together and not in our own shops in our area of expertise, is that we really form those key partnerships. We're creative, we're nimble, we move with the times. And so recovery, I just see is absolutely 100% connected to these broader societal issues, and that we need to really work together, collaborate. Unfortunately, we're in a divisive time right now, but we really need to fight through that and make sure that we work together to kind of be creative and meet clients where they're at, so that they can achieve this recovery we're talking about.
Great, thank you.
Of course.
I'm now going to have the question for the panelists. It's being focused on your particular area of work. Then we'll open it up a little bit broader. But Dr. Wolfson, what are the new approaches that the emergency room are employing? Are they working? Are they changing outcomes? And what gaps remain? What more needs to be done? And if we were to raise hell with the medical center, that huge behemoth on the hill, to do more, what should we be urging them to do?
Thanks, Peter.
You don't mind if I put you on the spot, do you?
You know I work for them, right?
Right.
Okay, well, here's the thing.
This is being taped also.
Here's the thing. It's really bad. The drug situation is getting ever more complicated. When we started this work 7 years ago, it seems like, it was heroin, and then that changed to fentanyl, which is more and more potent and stronger and harder to treat. And the simple formula of starting people on buprenorphine is not so easy anymore. A lot of folks find that when they try to start buprenorphine, Suboxone, because it's only a partial agonist of the opioid receptors, they have a sensation or experience what's called precipitated withdrawal. And so it's just harder for people to wait long enough to start Suboxone or to tolerate it when they do start. And so our experience in the ED has, we've had to be very nimble and adjust things as we go. And so we started by offering people buprenorphine, and now we also offer methadone in the emergency department. And that's not very common around the nation. So we're trying to pioneer some pathways for that. And then methadone is better tolerated. It's a full agonist, so when you start it, you're not going to have precipitated withdrawal. But it's also, too much of it can suppress breathing, so it has to be done extremely carefully, and there's a lot of regulations around using it. Even that landscape has been changing. The dose we've had to increase, and fortunately, federal regulations changed in 2024 to allow us to start people on higher doses of methadone and get them titrated up more quickly. So we're working on figuring out how to do that, how to do it safely. We've expanded EMS, the emergency medical services ability to start buprenorphine in the pre-hospital setting as well, because I'm pretty sure there's some patients that we've never even seen, even in the ER, who just never make it and maybe never touch the medical system. And EMS might be the only part of our medical system that ever touches them. So we've been training, and Burlington Fire Department has stepped up and is participating in this program for EMS buprenorphine. And actually, thanks to them, we've adjusted the protocol so that not only paramedics can start pre-hospital buprenorphine, but so can the advanced EMTs. And I think Burlington is the first EMS agency in the country that has advanced EMTs starting buprenorphine. So they're still learning the protocol and getting it going, but I'm feeling very optimistic about it. I'd say the last thing is just that we can do all this treatment, but the thing to make noise about, Peter,
Yeah.
is when we do that, we really need somewhere to safely send these patients.
Yeah.
I get them started in the ED, we get them on methadone or buprenorphine, and then a lot of them just don't have a place to go. And it's really hard to stick with treatment and stick with recovery if you have no safe place to go. So love to be able to work that detail out.
Great. Dr. Dan, I put you on the spot. Could I put you on one more spot? Is there anything coming at you from the federal government that it has implications or is constraining the work that you're doing? Or is there anything that you're fearful of in terms of federal dictates?
Well, obviously there's a lot of stuff going on in the federal government
Yeah.
right now. Some of our programs are grant funded. Fortunately, we have not lost any funding yet, but we have had to kind of re-explain some of our services. So instead of referring to some things as harm reduction, we're talking about it preventing fatal overdoses.
Yeah.
And things like that. But, you know, I think the biggest thing is there are a lot of regulations around methadone, which are there for a reason, because like I said, methadone can be dangerous if it's not used properly. But it also makes it very difficult for people to access ongoing treatment with methadone. And so if there was a way to make access to methadone more accessible, I think that would be a big help, and that's coming from the federal government, I think.
Thank you. Candace, you know, we oftentimes put things in silos. We have a silo for addiction, we have a silo for mental health, we have a silo for homelessness. You know, it sounds like your work is focused on making some connections between those silos and providing recovery residences. Could you say a little more about both the progress that you're making there, as well as the barriers and the challenges that you're facing in terms of providing safe, stable housing for those that are hoping to travel the path to recovery?
So recovery is a long process, and really the recovery continuum, how we've all been working together in our different silos to really create easy transitions and make that experience as easy as possible for those that do want to recover. The main benefit really of recovery residences is that we want to take people that are coming out of treatment and don't have another place to go after that. We don't want them to return to the community that they were coming from, where they were around a lot of individuals who were also using. They're in an environment that's not the healthiest. And so what happens when someone comes out of treatment and they come into a recovery residence, they have that community of others that are going through the same thing they are. So they have that support amongst the other members of the home. And then they also have the support of our staff. And our staff are really there to guide people and connect them to the resources so that they can go and get mental health help or physical health help, or they can go get their license or their social security card. They can work on purchasing a car. We connect them to employment services. And this, with all the things that we do, we really want them to build those life skills and those recovery skills while they're in a recovery residence, so that when they leave our homes, they have that foundation already. And that's really important. So for our recovery homes through V4, we have almost 10 homes throughout the state, 79 beds. We have 5 houses for women and 5 houses for men. And we also have our transitional apartments, which are a step up from our recovery home program. So when you start out in a recovery residence, it's about 6 to 8 people that are sharing a single family home. They have their own bedrooms, and then they share communal areas, the kitchens, the gyms, the living rooms. They also have to work or go to school or volunteer 20 hours a week. They need to keep up with their recovery goals. And this is really building that accountability. And really helps as people are learning how to recover and learning other skills on how to survive outside of a recovery residence. So they're able to stay for up to a month or 12 months, depending on their need. And then if they are successful after 12 months, then they're also able to apply to our transitional apartment, which is basically a step up. It's a little bit more accountability. They would have to furnish their homes and start paying for their utilities. And they're also able to have their children or their partners live with them at that stage. But they're still under the V4 umbrella. They still have the support of the community. They're going to monthly house meetings. They have recovery goals. They still have the same goals for working, going to school, or volunteering. And at that point, we're really helping people find stable housing. And that's really important because working with the recovery centers and being able to have our members go to a recovery center to get the skills that they need, being able to help them find mental health help if they need mental health help, or if they need MOUD treatment. And so really connecting to those resources, and the better that we can all work together as partners in this field, the easier our members are going to be able to transition to the different layers of what they need. And so that's a lot of the barriers that we find is making those connections and making sure that we have those relationships with other partners so that it's as seamless as possible.
Thank you very much. Dan Hall, I note that recently Howard Center has been in the news. You're in the news often. Most recently, I recall, it's been about the needle exchange, and it seems like it took an extensive journalistic investigation to discover that there's more needles going out the door than are coming back in the door. I'm not certain it took extensive investigation to prove that, but that's not what I want to talk about. What I want to hear from you is what's working. The programs, the initiatives that you're offering through Howard, in terms of mobile outreach, harm reduction, and treatment courts. What's making a difference in people's life, and what's connecting people that are seeking recovery? What's supporting them on that road to recovery rather than sending them on a road to punishment?
Yep, great question. And yeah, let's talk about harm reduction. It's a hot topic right now. A lot of discussion, a lot of feelings about it. So it's relevant. So harm reduction, it's a set of principles and practices that are really, aimed to reduce harm for both the individual and the community. I think it's important to remember that harm reduction is meant to reduce harm to the community as well. So there are a cohort of folks, clients, community members, Vermonters, that for multiple reasons aren't ready to stop using substances. Maybe it's the many barriers we've talked about, housing insecurity, food insecurity, and maybe it's just they're not ready to make the change in their life at this point. We believe that they deserve our respect, they deserve our compassion, and they still deserve access to services, and those services can look different. So what's working well is, Vermont has a very low infectious disease rate, one of the lowest in the country. That is in big part to the services of our syringe service programs throughout the state. We have Narcan readily available. People have that in their purse. People are probably carrying it today. It's in multiple sites. It's available if you want it. We have access to drug checking and a host of other kind of interventions to really reduce the risk of overdose. So there's a lot that's going really well. You mentioned syringes, and I don't want to make this all about syringes, but there is a lot of collaborative effort going on, more than I've ever seen, to really address that. So I think that's a positive. It is an issue. I think we also need to take into consideration that when you see those numbers, that's representative of a demand, a need for services right now. And we educate and we really encourage proper disposal. So when you see that disparity, 50% coming back to a syringe service program is actually a pretty good number. The bulk of those are getting properly disposed of. So some of the things that are, also working well as far as kind of on the more harm reductive side of things is we really are trying to tailor services that are meeting clients where they're at, both physically and both in their journey of recovery. One of the initial, for a lot of people, one of the very first kind of pieces that happen in their life that really make them start rethinking their relationship with substance use is usually a law enforcement intervention. So we've realized that and have multiple partnerships with law enforcement, from probation offices to judges to these treatment courts. And so what we do in treatment courts, and we have 6 of them, 3 at the federal level and 4 at the state level. That's 7, but we have multiple treatment courts, and so when someone's charged with a crime and it's a collaborative decision that this charge is really related to substance use or mental health versus more criminal behavior, they can enter this court and have access to a team of case managers, clinicians, where they kind of get a host of wraparound services, and in the end, upon successful, hopefully, graduation, that charge can be reduced or even dismissed. So our treatment court programs, and they're throughout the state, are really a great partnership. The more we can partner with law enforcement to make access treatment and other services, I think the better. We also have a mobile outreach unit, which is a really kind of cool initiative. It mostly operates in Franklin and Grand Isle County because we really recognize that the rural nature of that part of the state. But it's essentially treatment on wheels, and we set up in places like Alburgh, Richford, and Swanton, and clients in those areas who would have trouble getting to St. Albans or to Burlington can access some of the services that we offer out of those. I think some of the main kind of principles are really like, the more that we can offer services embedded in areas where they're already getting services and provide kind of more wraparound care, the better outcomes we're going to get, and that's what we're kind of trying to do.
Dan, do you know the number of people employed by Howard Center?
Staff?
Yeah.
It's between 1,400 and 1,600.
Yeah, I just heard that number. I was, I don't know what folks think, but a remarkable resource to this community and doing some real heavy lifting.
Yeah, I think if you read the news, all people might think is that we're a syringe service program.
Right.
But, that's a very small kind of book of business for us, but it's a critical piece because, again, we want to serve clients on any spectrum of their journey to recovery, all the way from sustained abstinence to those that really just are trying to stay alive and be safe until they can make a different choice in their life.
And I'm not certain why I'm not going to put you on the same spot that I put the other Dan on, but I'd be interested in hearing, and this could be a forum by itself, what are the implications of the federal actions on Howard Center and how are you going to be affected? But we'll save that one for another day. But, BBF is an interesting organization, only launched in early summer. And we're first and foremost an advocacy organization. We don't have all the answers. That's one of the reasons we're hosting this forum this evening, is to hear from experts, to hear from community as well. But for us to be effective advocates, we need to know what you need. And you also have in this audience, and we've locked the door so they can't leave, but representatives, elected representatives, both from the city council as well as the state legislature. So just very, briefly and succinctly, recovery first sounds very noble, and how can anybody object to recovery first? But what local actions, it's not simply about money, but what local and state actions will have an impact. What resources do you need? What support do you need in terms of placing recovery first, whether it's funding, whether it's coordination? What do you need? It's one thing to walk through City Hall Park in bemoan the conditions there, but if we're really committed to supporting folks who are committed to recovery, on that road to recovery, what's needed
I'll
to travel that path?
Yeah, I'll reiterate what's already been said, just because it's at the top of my mind. But the housing piece is critical, and we see this so many times from a treatment perspective. They may go to a residential program, or they may be coming out of incarceration, and they're right back into the same environment that they were before. And so I really do think that there is some work to do around finding some sort of additional kind of recovery, short-term, long-term recovery options, housing options for folks, so that they can have more of that sustained and not continue to just be in that cycle. And then, you mentioned funding. Obviously, funding results in staffing, and so the more fully funded our programs can be, the more fully staffed they can be, and just kind of enhance and do all the great work that we're doing. But practically, I do think that there's some pieces around housing that I think is an area for growth for Vermont.
Okay. Candace? Yeah. Or Cam, do you want to?
Yeah, I was
We'll
just
break
gonna,
we'll break
Can we
things
get out
down.
of order? Is that
We don't need to. Yeah.
There's a piece that kind of keeps coming up, hearing everybody kind of respond and kind of reflect, and I see many frontline, like first responders, folks, street outreach, folks who work in the hospital, and folks from our organization. More often than not, when we're engaging with patients in the emergency department, and we're providing our emergency department recovery coaching service, we are being honest. And we're saying, you know what you might have to expect is that you might have to leave here. You might have to leave this safe environment, and you might have to actually go right back to the place that you associate the most with your current use. And then not only that, we're hoping to continue to make contact with them, because once we make contact, we don't stop. We call them every single day. We make sure that we're doing the best that we can to manage those expectations, but from a point in time, we've switched from being able to plug people in and be upstream and think preventatively and think, okay, this is what you're presenting with. These are options that you have. And the options, that really elicits a response of motivation. People are already motivated once they come into contact with us. We just don't know what it is that they're motivated to change. It's up to them and what they're going to make that change is. But when we can't get them from one thing to the next, we lose trust. And losing that trust is critical. And so my organization has been focused on rebuilding trust after the pandemic. There was a point in time we were getting calls from the hotels and motels every single day. Cam, can you come up here? Cam, can you get somebody up here? just to connect, just to talk. And our friends at Howard Center inundated heavily in the emergency department. Our friends who are physicians in the ER inundated, not just with a pandemic, for crying out loud, but after the pandemic and things opened up, we saw a rebound effect of use disorder, prevalent use disorder, presenting concerns all throughout emergency medical settings. Alcohol use disorder is the #1 most predominant substance in ER settings nationally. I had the pleasure of working with Dan Hall on developing an alcohol use disorder rapid treatment access. The hardest piece was how to manage expectations and understanding that, hey, for treatment of alcohol use disorder, we're looking at higher levels of care. But if patients are stuck in this catch-22 where they're not acute enough to be in a hospital setting, but they're too acute to be in a residential setting, what are we going to do? How are we going to manage those expectations? So how else can we be plugging people into the effective solutions, the effective treatment for them to have a leg to stand on and being released from these incredible touch points every single time we are engaging with this population? It's an opportunity to affect progress towards healthier outcomes.
Yeah.
There's agency from us all that's here, but I do want to recognize that over the years, there's been an obligation for all of us to be quick, react to this, react to that. How else can we build on the progress that's here and start looking more upstream and say, you know what, are there other places that we can plug people into? Can we enhance our current infrastructure?
Great. Thank you, Cam.
Yeah, it's a really great point, and something that we still struggle with is, and what we've been calling like the missing middle, when people are coming from treatment and they might need a higher level of care, where do they fall? For V4, we're level 2 certified recovery residents, and that is a good place for a lot of people, not everyone. But what we try to do is work with those that are in treatment while they're in treatment to make sure that they have all of the paperwork and that they can go door to door, because that is what we don't want to do. Is we don't want to lose people through those gaps. We don't want them to get out of treatment and return back to their old environment. If they can come into a recovery residence and they have, you know, that 1 to 2 years of transitional housing, then they have a little bit of support and time and space while they're healing, and they have that community around them that they can leverage. You know, it's not a perfect system, and I think the more that we work together, we're really trying to provide a better system. And also, you know, if we have someone in our homes that goes through a recurrence, and they may need a higher level of care, having those relationships with those treatment centers to send someone back to treatment and then have them come back into a V4 home is really important. And it's also very important on the other side. Once people enter our homes, we try to get them fill out all of their housing paperwork so that they can start looking at stable housing or permanent housing when they're ready to leave our program. Because again, if someone doesn't have their basic needs met and they don't have a roof over their head, they're not going to be successful either. So it's really important that we are doing our best to work with either the affordable housers, the treatment centers, the recovery centers, the Jenna's Promises who offer a higher level of care, and the Valley Vistas, and Serenity Houses and all of those out there, so that we can make sure we're not losing people through this entire continuum. And it's an ongoing thing that we have been trying to solve. Obviously, you know, funding is a huge portion of what we do. Being able to maintain our funding, we have, you know, almost 79 beds in the state, but there are states that have 500 to 1,000 beds. And we really need more recovery residence beds or sober living beds in the state, to be able to catch more people, because, you know, we just don't have enough of that right now. At least from Burlington, our closest recovery residence is in Essex. We have 24 beds, and that's half for women and half for men. And then we have 4 transitional apartments there. So it's actually our largest number of homes are in that area. But as we look to expand, what does that look like coming into an area like Burlington? We try to stay very spread out around the state as much as we can, but we also rely on funding for opening new recovery residences, but also making sure that our current continuum has the funding so that we don't lose the resources we currently have, which is really important.
Thank you. Dr. Dean?
Well, I know we're up on the hill, but let us do the research and support that. We've developed the pathways for starting buprenorphine. Not every ED was doing that in Vermont. Now it's commonplace. We're developing the pathways for shared decision-making to start methadone. Most EDs don't do that. Now we're learning and studying how to titrate methadone up more quickly. And there's a lot more stimulants out there. Cocaine is everywhere now, and the overdoses are mixed. And there's no clear guidance on that. We're looking at how to do that, and then sharing what we learn with other medical providers across the state. We're looking at contingency management therapy for stimulant use disorder. So we need that. We need support. We need support for the academic mission and doing the research that really does flow out to providers all across the state and even the nation. And then the housing thing, yeah, like we need a safe place. It's a cold, rainy night. I don't like having to kick people out of the ER on a cold, rainy night or give them a tent. It's just need a safe place to send people.
Great. Not great, but good to hear. You know, I think those of us on this platform agree that recovery programs and efforts need to be more visible, need to be better supported, need to be stigma-free. We've talked a fair bit about the role of government, state, local, federal government, in supporting recovery efforts. But as I look around this audience today, I see folks that are outside of government. There's a number of employers here, representatives of the business community, our neighbors, community activists. What plea might you make to them? What can they do to make Recovery First more effective? Just ordinary folks, ordinary citizens, and employers.
I mean, I think about engagement. Just the word that just comes to mind is not to shun away, but to engage, and that could look multiple different ways. You're all here, so you're already engaged. When you see a divisive post on Front Porch Forum, ask a question. Be curious about why that's coming, and maybe ask some questions, push back. I think engage in the conversation. There actually, I've been learning more and more about different volunteer opportunities that are out there, advisory boards. Howard Center is always looking for people to join its substance use and mental health advisory boards. So there's just a lot of different kind of opportunities to kind of learn more, to engage, to offer feedback. What are you seeing? We see things from a treatment perspective, but sometimes that's different from a community member's perspective. So to stay engaged and to try to stay away from some of the divisiveness that's out there, and be curious. If you don't agree with something, ask why, ask for more information. But that's what comes to mind, and it never hurts to also advocate, whether it's with legislators or council folks, about the need for funding and resources to support these programs.
Thank you. Candace, anything you'd like to add?
Sure. I think, we have a lot of community members that will volunteer. They will come into our homes, volunteer once or twice a week. We definitely are always looking for people to join our board. I think that would be a phenomenal way to get involved. Even donating for new houses or current houses if we need furniture or clothes or bedding, we have received so many wonderful donations. And even just donating a small amount to the programs as well, so that we can do more for our members, and then we can open new homes at a quicker rate because we do have that funding. We are in the State House during the whole legislative session advocating for recovery centers and recovery residences, and trying to break that stigma as much as possible. I think something simple as, talking to a friend that might not understand recovery and explaining to them what recovery is to you, helping to break that stigma, talking about, substance use disorder as a disease and not a choice. Simple things like that go a long way, especially with breaking stigma. So that would be some of my recommendations.
One quick question. So as you open a recovery residence, do you need a zoning permit, and do you sometimes encounter hassles in getting that permit?
Yes, we have encountered issues when we've been talking to the zoning boards. I would have to say, though, that over the last 2 to 3 years, it has gotten so much easier. And I think it's because stigma is finally breaking down. People understand the need. They're seeing people in their communities struggle with substance use disorder. They're seeing a lot of the homeless population. And so we've seen so much less resistance and, not in my backyard, which we used to hear quite a bit. Because when we come into an area, really, all of the people who live in our homes, they have chores. There's, video recordings throughout the house. Everybody is there for a purpose of recovering. And you don't always know your neighbors, but if your neighbor is a V4 residence, that they're doing everything they can to recover, and it actually reduces the amount of drugs that are in that area. And I don't think a lot of people see that side of things. So that's what we've really seen, and luckily we've had a lot of support from communities that we're going into, and it's been really opposite, where people are asking us constantly, please come to Brattleboro or Addison County or Burlington. We really need more beds in the state, and that has helped us tremendously, especially if we have those advocates in each of the communities that we're in when we're talking to the zoning board.
Great. Thank you.
Sure.
Anything to add, Dan?
Keep an open mind, speak without stigma, and carry naloxone.
Yeah.
Yes, always.
Thanks. Thank you all, sincerely. The business community, I'm the executive director, so that means I'm the agent of the board of directors, at which we're a business itself, and we are owners of property in Burlington, and working alongside everyone. Much has already been asked of the business community, and many are here now wondering, what else can we be doing? And so many contentious discussions brought about over many years. Everything is possible that's done up here. I ask, what else can I do for you? Is there something that maybe I'm not thinking about right now? Is this a new opportunity for a partnership or a relationship? We have friends here from Committee on Temporary Shelter, COTS. Much is asked of them. And as not-for-profit organizations providing immediate and direct services, all of which are essential, time and time again, we're asked to do so much with so little, and then asked to step in and to do more. And specifically with the designated agencies and Howard Center, us as a recovery center, we had over 21,000 visits to our center last year. That's 21,000 times people are coming in and engaging with us, serving over 1,200 lives, unique individuals served in our direct programs. The impact is massive. However, all of us require additional support. Each organization has more to learn from. And it's critical that I can check my ego at the door and say, you know what? I'm going to work with this housing expert over here, because what they're doing is incredible. And they know how to navigate this system. And we can work in our area of expertise, of recovery supports, and do a darn good job at that. How can we make this work even better? So we have a partnership that's developing and an opportunity to integrate care and to enhance the quality of service that is available in what has predominantly been a low barrier context. So that's an example of what I'm talking about, of a recovery first mindset. Can we lean on each other to embrace the great work that is currently being done, to build upon everything that we've progressed on, and to still keep in mind this can be better, and not settle for where we're at now, but really keep the eye on the prize of where we are going in the future for it.
And you do accept donations, right?
Yes, sir.
And the check should be made to?
And specifically right now,
Check
yes,
to be made to.
made to 501c3, not-for-profit, Turning Point Center of Chittenden County. We're in our annual appeal. If you got our letter, hopefully it was written by Eric Sokolowski, our board president right there. Thank you.
Okay. Last question. At fear of promoting redundancy, I don't want to do that, but I want to give you a chance to make an exclamation point. So if you had the magic wand and there could be one change that could be made or taken in Burlington to strengthen recovery in this city over the next year, what would that be? 30 seconds or less.
I see an amazing change that was just made as opening up what is due process and engaging individuals that have long been enduring over and over again criminal citations without being able to see a courtroom and without being able to engage in a robust menu of services that are already built into the judicial system.
Good.
I agree, Cam. Collaboration between the medical, the city, the state, hopefully federal, we'll see, to all work together like you're doing here tonight. And I have to put in a plug for this guy and peer recovery coaches. I just got to say, the peer recovery coaches are the magic sauce in the ED. Like, they are so incredible and brave and powerful, and they come and talk to our patients, and it just makes a huge difference.
And they show up in the emergency room.
24/7.
Wow. Yeah.
I would say a lot of the work that we've really been focusing on this year in each area that we serve is basically a memorandum of understanding, so MOUs, so that we can better connect with our community partners and make sure that we have something drafted so everybody knows their part, and that we're all working together and meeting on a consistent basis so that we can identify both things that are going well and problems that are happening, because we learn so much from those meetings and from working with each other to really help those people that need our services the most. And so if we can make that process easier for them, to me, that is a huge win. And of course, like making sure that we have the funding to sustain these services is one of the biggest parts of what we need for what we do.
Thank you.
Yeah, I'm going to keep the theme going. Creative partnerships that reduce barriers to the multitude of needs that clients are trying to access. The more that we can combine efforts and offer, the full spectrum of services, the better for the community.
Great, thank you. Okay, I'm going to take a risk, and I'm going to open this up for discussion. But since I'm the moderator and I have a mic, it's going to be on my terms. And these are the terms. As I look around this room, I see a lot of people who are community advocates and activists. I know you have a pitch that you want to make. And I want to urge you to make that pitch, but not tonight. I want to urge you, if you have something you want to say to this audience, please grab a card on your way out and communicate to building Burlington's future that pitch. Feel free to advocate. We need to hear from you. But since we don't have a whole lot of time, and since we have all these experts here, I don't want to open the floor for those pitches and that advocacy tonight. What I want to ask you to do is, if you have a question, ask it. If you want to ask it for the whole panel, fine. If you want to direct it to a particular panelist, that's fine. Is that fair? Okay. So who's got a question they would like to raise? Yes, I'm just going to go around the room.
Mm, 3 years ago, they were at their worst. And right now, where we're at, they are better. And concerning fatal overdoses, we've seen a whopping 5% decline, which means that that's forward progress, but nowhere near the end goal. Nowhere near. And in fact, the end goal means zero. There are 0 lives lost, and that there are 0 negative consequences resulting from prolonged use of substances. So the numbers that we see at our organization is also telling that when we see an increase, it is incredibly hopeful. And it's been a year-over-year increase for the past 5 years. I mean, well, let's just look at the 3 years, right? The past 3 years, year-over-year increase in individuals seeking additional recovery supports, engaging with peers, and working on their recovery, however they're presenting with. So that's hopeful. That's hopeful to see.
Anybody else have some numbers they'd like to share?
I mean, thankfully, our funders and regulators require tons of data. So if you have specific data at some point, happy to share. But I looked at the data today before this specific to overdose, and Cam shared where it's at today.
Great. Others? Ed?
Thank you, Peter. I just wanted to say that I feel very optimistic tonight that when I began my career in this field, everything that you do didn't exist. There was no hub and spoke, there was no mobile unit, there was no safe syringe program, there were hardly any recovery beds, maybe Oxford House. There were no emergency departments with low barrier group and open and recovery coaches. There were no recovery centers. I think, methadone was introduced at the Burlington during your tenure, was 2002?
Yeah.
So when you go back in history, none of this existed.
Introduced legally. Right, yeah.
2002. When you go back a little bit, not that far, certainly
Right.
one lifetime, none of this existed. It's people like you that have, if you look at recovery like a powerful river flowing toward health with ever-expanding banks, it's people like you who have expanded the banks. My question is, what's the next expansion of the bank? How does recovery or access do it? What's the next step in widening it?
Panelists, anybody care to take that one on?
I've got it in my very narrow lens of our organization, and that is robustly enhancing our low barrier outreach recovery coaching program. We have been building that program year after year with small pilot funding, and then has been continued with the Community Health Improvement Fund, thanks to UVM. It is a lengthy process, but that is a very small chunk of change for a program that does incredible work. Building relationships with individuals that are actively using, meeting them where they're at, and encouraging them towards healthier alternatives, but doing so at their time. Never giving up. Okay, so that is how we can widen the road and really embrace people for how they're presenting, but also understanding that they're always worth it and that we will never stop believing in them because we've been in those shoes. We know what they're going through.
Thank you. Others?
I will add that since September of 2024 till now, we have grown 42% in the number of beds that we have available through V4. And we are looking to next in, as I had mentioned, in Addison County, Brattleboro, and with others that are opening recovery residences throughout the state that might not be V4 related, but how can we help guide them to open those recovery residences? Because it's not just us who has to open them. We want to make sure others have the opportunity because we know we need so many more beds in the state. So really trying to provide that guidance for others that are opening new recovery residences so that they can be successful and they can add to our portfolio of beds in the state, which is really important.
And I just appreciate your perspective. Sometimes it's hard to see the positive when there's a lot of focus on the negative, so I appreciate the historical perspective there. But I think staying up to date, looking at the most recent research, we talked about contingency management is something that we're trying to provide more of. So I think it's ever evolving and not getting stuck in one way, but being able to read the landscape, read the environment, look at the data and what the research is showing, and adapt to provide those services.
We're not allowed to admit people to the hospital for opioid use disorder treatment. We can admit them for alcohol withdrawal or treatment, but not opioid use disorder. A lot of people, I think, would actually benefit from coming in, getting their medications titrated up, getting stabilized, and it's a federal thing. It's just not allowed.
Yeah. I might also add, when you think about going forward and what's next, you also ought to be looking through the rearview mirror. And one of the lessons that we learned when the first methadone clinic was opened is that the opposition to that was in part overcome by, I might say some political leadership, but But seriously, the key was the collaboration with the medical center at that time. That really was the key to the breakthrough. I saw Joe, and then I see Gary, and then I see Patricia. In that order we'll go, Joe? Yeah.
Joe Hagan, retired pediatrician. I have a question for each of the Dans about collaborative opportunities. Dan, my colleague, nice to see you again. Thanks for the work you're doing.
Hi, Jeff.
Hi. I happen to know, because of my service to the hospital over the years, and currently on the board, about the network, which is not always a very happy topic these days. But have you been able, through your work in our ED, I know that we operate the other EDs as well, are you able to share this to the two other Vermont hospitals and our New York hospitals?
Yes. So Yeah, no, in all seriousness, our program, STAR Treatment and Recovery, we've expanded it to Central Vermont Medical Center. They were already doing buprenorphine really well. They have a strong program there, but we expanded the methadone initiation. We've expanded it to several of the hospitals up in New York, and it's also getting expanded into the inpatient, both buprenorphine and methadone inpatient settings as well. And we're hoping to go well beyond the network and expand it to other emergency departments across the state and the region.
Thank you for doing good work. And on my other hand, we recently at the hospital opened a mental health emergency room, and I know that Howard is very much involved with that. But there's so little I know about that. How is that connected to substance use? I mean, I can remember being in practice for 42 years down the road here, and when there was a crisis with drugs, or we needed help immediately, it was the ED, period. That's all I had. There was no other colleague I could call but the ED. So what's available now?
MHOC, Mental Health Urgent Care. It is a kind of alternative to the emergency room. It's a Howard Center program staffed by clinicians and care managers in partnership with some other entities, including UVM. And yeah, it's really philosophy is that the client defines the crisis. So is it a mental health crisis? Is it a substance use crisis? Is it some sort of other crisis? You know, we don't provide detox services there, but it's a lot of triaging and working with the client to find the right services.
And are you connected with the university? Not the medical center, the university in general?
Interestingly, a lot of the requests for services, a lot of the people showing up are connected to the university. It was an interesting, it's a whole kind of new cohort of patients that we weren't seeing through some of our traditional means, and a lot of them are connected to the university.
Co-location.
Yeah.
Thank you. Gary.
One is that I know that the Vermont legislature has really stepped up their financial commitment to both recovery centers and recovery residences in the last couple of years, which has been quite remarkable. At the same time, I'm aware that the city zeroed out your budget, Cam, in relating to your recovery center right here in Burlington. And I guess the question would be, what do we need as a community to do to make sure that that doesn't continue to happen?
Thank you. Well, many things change as administration changes, and so is one of the line items in a regional programming budget. And I think it was really unknown to many folks that cared a lot about having that line item in the city's budget, as it has been in the budget since 2013. And not only that, there was an increase in a commitment from the city in responding to a growing number of Burlington residents, housed, unhoused, that are being served and are sustaining their recovery through our organization. That budget increased, so the line item for us had increased. I know that there is direct action being taken both in partnership from City Hall, City Council, and also the rest of the community to really make sure that it is prioritized going into the next budget planning. It was recognized in this current budget that we're in as it was being presented and discussed, and thanks to current mayor, thanks to City Council, and really working together to find some funds in place with the understanding that future forward, there's real sincere desire for continued investment in our supports.
We're not talking a lot of money, are we? Level funding would be how much?
17.95, so $17,950.
Yeah.
It's not a whole chunk, but it is incredibly meaningful. It's $50 per Burlington resident. We provide supports 365 days a year. It's really everything that is outside of the billable hour, and it falls outside of all of the hours of, direct medical care, clinical supports and therapy and counseling. It's a robust community environment for people.
Great. You had another?
The second question is related to Maple Leaf Farm, which was a significant residential treatment program here in Chittenden County, 30, 40 beds that evaporated 6, 7 years ago. Well, it's never been replaced as far as I know. And what impact has that had on your work when you're trying to move someone from the emergency department into some treatment? And the 2 treatment centers, one's in southern Vermont, the other's in the Northeast Kingdom, and we have 0 capacity here. What impact is that having on all of them?
I often look at Dan and say, well, I don't know what else to do. And I talked about it earlier that and Dan, well, Dr. Wolfson and Dan, so 2 Dans. Every time I look this way, you all are wondering which Dan I'm talking about. So Dan, it is depending on what the client's perspective is, and it is client directed, as is all care across the continuum, that it is person-centered and driven in partnership with the client, with the individual. And as it presents, individuals are oftentimes wanting a higher level of care. It isn't always the case, but when it comes to alcohol use disorder, when it comes to long, chronic use of substances, much of the earlier preliminary treatment attempts were utilizing outpatient treatment, intensive outpatient treatment, medications, med management with primary care consultation. Putting all those pieces together, many people have already tried. And the next step is to try something different, right? So managing expectations is critical, but really helping people understand that they're kind of set up for failure. In its current state, it's hard to get people into what used to be same-day access, same-day bed capacity, same-day walk-in availability. And I know Howard Center's done an incredible job of opening up the channels for walk-in capacity to induct and prescribe medications for opiate use disorder. The emergency department has built out its entire care system to embrace access for medications for use disorder, opiate use disorder. So we're seeing a lot on the lower levels and a lot of nimble planning, but in the higher levels of care, it's often restricted due to what is reimbursed under the Medicaid dollar, what's eligible for reimbursement, and so maybe there's an opportunity for some creativity in restructuring that and just getting more beds available.
We heard at a board meeting that you were at, Cam, that the typical treatment, in-house treatment program in Vermont is for 14 days? 21.
Yeah. Used to be a pretty recognized 30-day process. It's kind of been understood. 30 days. Oftentimes you can get a medical necessity put in from your care team to extend that for another 15 days, so 45 days. A lot of that changed because of what was eligible for reimbursement, and also the pressures put on the providers to keep their current operations open, because it is an obligation. So it's a real tough predicament that they're in. 14 days to 21 days, we're talking about redirecting and changing a lifetime of learned behavior too.
And New Hampshire, 60 days. Yeah, I would urge, I see some legislators out here, just scratch that surface and try to figure out why New Hampshire can provide 3 times the treatment opportunities as Vermont. Anyways, Patricia.
Hi, I'm Tricia Pomelo. I was born here, raised here, left for 35 years, went to high school with that bandit right there. And
No stories, please.
I'll keep that in that bucket. I'll put it on a card as I leave. I've run hospitals, I've run emergency rooms. I was handing out methadone in paper cups and orange juice in the 70s before there was any regulation whatsoever. So that's how ingrained I am. I have great empathy and for those who are in the throes of drug addiction. I've dealt with it, my entire career when I was running hospitals. But I also have great empathy for the community. And so what I've heard tonight, it has been incredibly well put. But I would like to see messaging from your collection of individuals, and I think PBF can help in terms of, because you're going to have to go out for more fundraising. The federal government, God knows what's going to be happening, and we need to maintain all of these programs. And in order to get funding, you've got to tell the community what's in it for them. Not just what's in it for the individual person who's abusing drugs or in the throes of alcohol, withdrawal. You need to tell the community what's in it for them, how you're going to be able, how your initiatives are going to make this community safer, how you're going to be able to use the parks. If you want to raise money, you've got to tell people what's in it for them. And I don't know if you could have thought about that and have messages about that, because I just think it's really critically important, because I want to see all of you grow. And I want to see you all get more programs and be able to reach more people. But at the end of the day, I want my businesses on Church Street to thrive. I want my park behind City Hall to be safe for me to be able to walk through and not be scared of. So if you have thought about that or have some ideas of how to get that message into the community, I would jump on the bandwagon and help you.
Thank you. Andrew.
My name's Andrew. I'm going on my second year being the downtown ambassador for the business district in the downtown. I do a lot of stuff, too much to mention in the next minute or so, but I've got two questions that are very, very separate. Number one, I've noticed that through some very intense, close relationships that I have with people in the addicted homeless community downtown, that when a certain kind of opiate is not available, they do not actually go through withdrawal. They go through the missingness of whatever series of trank is inside that substance rather than the opiate itself. And we have not talked about that too much tonight, and it's not being talked about too much, to my knowledge, here or nationwide. And I think that's a whole different other topic. So what, if any of you have any details to say about that, I'd appreciate it. And number two, very, very different, very powerful question, somewhat controversial, and I don't mean it to be. What role does judicial intervention play in the journey of recovery? And do you think that you have a partner in judicial intervention here in this state? And is something missing, or is it a robust partner? Back to the last question that Peter asked, if you could have one thing, is that part of it? What role does judicial intervention play in the journey of recovery, according to you? Thank you.
Anyone want to take on either or both of those questions?
So I heard very similar on the ground feedback about the substance piece, and I agree. I mean, as substances change and people shift, what was working before may not work, and it's kind of scary to think that we put all this effort into fentanyl, and then if it switches to something else, we need to, and that's where we need to really be adapting and looking at the research and what's the next thing we need to come up with. I mean, I talked a little bit about the judicial intervention and treatment courts. I mean, I think it's a huge opportunity for partnership. For so many clients, that is the starting point of their recovery journey. It was a criminal justice intervention, and so the more that we can partners so that the response is not just punitive, but it's got a treatment component to it. That's key from my perspective. And so the more we have of those partnerships and the more we can steer, hold folks accountable, but also introduce an intervention or a therapeutic response in addition, that's where a lot of folks, again, that's where they start.
I'd like to add just one more note. I met Judge Griffin for the first time today, right outside of his courtroom, talked to him for 15 minutes. I've noticed that I'm in touch with a lot of people that enter his court on a day-to-day basis. And many of those people have very, very brief judicial interactions, but not any interactions that might prompt a change of behavior or motivate them to get out of the cycle that they're currently in. And I thanked him for his work, but that's what prompted my questions. I forgot to say.
Thank you. So I kind of spoke to it a little bit earlier, but kind of like if I had, that 30 seconds piece, if I had a magic wand, what would it be? And well, due process is a good thing. That our courts can function for the rights of the individuals residing in Vermont that are currently undergoing the judicial process, either they've got criminal charges, civil, and having been through that process myself, there's an additional enhancement for motivation that comes with that underlying consequence. I'm not going to beat around the bush. When your back is up against the wall and faced with jail time, that is a sincere catalyst for motivation and change. Knowing that, I've lost all trust with my family, I've lost all trust in my community. Who I am as a person doesn't reflect my actions. Who I think I am doesn't reflect my actions because everybody thinks I'm not safe to be around. It's an opportunity for a wake-up call, but still understanding that we're working with and trying to help people recover from a fatal illness that's, if left untreated, will die. That it is so profound and so unique that why isn't there a single prescribed pattern? And it requires its own unique care plan and done in consultation. So addiction is incredibly challenging. And if we'd have figured this out, we wouldn't be here having this discussion. We'd be arguing about what color, sidewalk chalk we could be putting out there for everybody to be exploring pathways of art. But no, we're here talking about pathways for people to stay alive. And it's a great topic. So there's always an opportunity for change. That change can come from motivation. Motivation can be brought on from holding consequences, but also so long as it's warranted. And it's also determined by the legislation, it's determined by the judges, right? It's kind of out of our hands. And we want to see people succeed. And there's no reason for mass incarcerations because we're not in the 40s, This isn't alcohol prohibition. We've learned so much over time. People in recovery add so much value to the community. They bring about change in everyone else. They give back to others. They help others recover. They get jobs. They build careers. They get families. They plant roots. They run for office. Sometimes they're representing people in a court of law because they're lawyers. So just giving you an example of the profound impact of recovery and how a system as it currently is functioning is making changes, but I ask you all to think, what else can be done? How can we build on all of this?
That's your speech for the community, right?
Hey, yeah. Okay, I see a lot more hands than we have time, but I see one persistent hand, so I'm going to take one last question over here in the corner. Then we're going to wrap it up, and I Really appreciate folks hanging in there. How many beds are an adequate number of beds for in terms of treatment, right? Yeah.
For treatment, not recovery residences, which are different. Okay, well, I know at least for recovery residences, we're trying to reach 500 beds in the state. Right now, we're about 140 beds
Wow.
in the state, so we have a ways to go. And they're at all different levels, certification levels, some that are not certified and some that are. But yes, the overall goal is to reach about 500 beds within the state.
Great. And for treatment, anybody have the number there?
Yeah, that's for recovery residences. Treatment is different, and I know that is something that's being worked on actually right now because of the limited amount of treatment beds that we do have. I know that there's going to be an additional 30 beds opening back up in Virgin's co-ed beds. I don't know the timeline on that, but I know that it's one of the biggest focal points in all of the groups I've been a part of is how do we get more treatment beds, and then how do we get beds that are at like a level 3.1, 3.7, a higher level of care, because that's really the gap for some people who might need a higher level of care between treatment and recovery residences. So it's a big topic of conversation right now.
Dan Hall, quick question about are you able to share a bit about what that kind of ASAM / level of care structure is, and what might be a higher level of care, 4, 3.1, there's kind of some jargon.
Yeah.
I'm speaking in jargon, so I could use some help.
Because we do not operate residential, I actually can't speak. I think the real difference is like medical complexity and what sort of medical services. So, that's where you start getting into those higher levels of care, is when there's more medical complexities and what you're offering has more of a medical bent to it. But I don't know the specific differences between what one level and next.
Thank you.
Great. Yeah. Well, it's been a great discussion. I'm going to commit to the panelists. If you have any specific questions for any of them, they'll stay here and answer them after we wind things down, won't you? For at least 5 minutes. Yeah. No, yeah, y'all have very important and big jobs to do. I appreciate you taking the time to be with us this evening. And this event was co-hosted by BBF with Turning Point. Since BBF had the opening words, I'm going to give you the opportunity, Cam, for some closing words. But since you gave such a great speech, I don't know if you need to say more.
Yeah. Can we give Peter a huge round of applause?
Thank you.
Just want to acknowledge everybody here, everybody taking time out of their Thursdays. Enjoy the rest of your evening. We took away a piece of feedback, something about parking or whatever. Maybe for the next one there'd be more parking, but it's Burlington, so I don't know. And immense gratitude for all of my colleagues up here and their leadership in their field and how hard it is to continue to show up day in and day out and do what they do.
Thank you. And BBF has a small but very effective team, staff of 2. They're here, Sam and Emily. Let's thank them for their work this evening.